Good afternoon, Dental XP. I am honored and pleased to be able to share with you some of the coordinates, parameters, rules, and workflows which we use in a daily office in order to get to the maximum aesthetic result on implants and on natural teeth.
You shout it out, but I can't hear a word you say. I'm talking loud, not saying much. I'm criticized, but how your bullets ricochet. Shoot me down, but I get up. I'm bulletproof, nothing to lose. Far away, ricochet. You take your aim. Far away. You shoot me down, but I won't go. I am titanium. You shoot me down, but I won't go. I am titanium.
The human body is a piece of art. It is a nice composition of functions and aesthetical aspects. And implant dentistry is more and more a symbiosis between art and science. There is a science already because it's not an empiric domain anymore. We have certain proportions, parameters, rules which we respect and which leads us to predictable results. But it is an art because in the moment the patient steps in our office, we are able to visualize the end result of our work, the teeth that the patient will get from us. And what a patient would like to get from us is the long-term aesthetics, stability, and function. And implant dentistry is so challenging and so fascinating because it is in the position to re-establish function, aesthetics, and stability almost no matter of the grade of the atrophy of the stomatognatic system. But the challenge is not only to reproduce in the mouth some golden proportions with the help of technologies. Our ambition and our vision is to give the patient a smile, create the creation of a smile which is the expression of her emotions. The art in implant dentistry is also to take the technologies, the techniques, methods, materials which are the most minimally invasive, make the treatment fast, effective, predictable, but in the same time giving us the maximum aesthetic result. This is the art and the challenge. Now, there are parameters which are well known in the planning concerning implant position, concerning contemporary implant design, concerning new methodologies of grafting philosophies, and also details in the prosthetical parts, in the provisional and final prosthetical parts. Now, concerning planning, we have new technologies today. We are able to visualize three-dimensionally the structures. We are able to plan 3D bone blocks, which we screw individually in that defect. I cannot even imagine how we could treat a defect before when we had only a two-dimensional picture and we didn't know the architecture of the structure or the defect. We didn't know where to do the incision and so on. Now we can do today the digital planning of the implant if we want to, in a perfect aesthetic place, in a perfect anatomical place with the protection of important anatomical structures. We are able today to do virtually a virtual planning of the emergence profile of the abutments on implants and on natural teeth. But nevertheless, which technology we use, we start with the planning by showing the face, by looking to the face. And the lower part of the face gives us the occlusal vertical dimension, which is decreased or increased depending on if the patient is a bruxist or it has a vertical bone atrophy. The occlusal vertical dimension gives us the crown height space, which is the distance between the bone level and the incisor level of the teeth in the frontal area or the occlusal level of the teeth in the lateral area. Now we know from Carl Misch that the planning in full arch reconstruction starts there, where we know how much is the crown height space, which we have to treat. If it is between 8 and 12 millimeters, then in very many situations we are able to do a very natural outcome with immediate implant placement, perhaps also immediate loading. When we have a crown height space between 12 and 15, then the teeth will be longer and inclined. And perhaps we need some small pink component in order to support the lip and to improve the profile. And this is something that you have to talk with the patient about if he gets a screw retained restoration and the reality that he gets a pink component. Then when the crown height space is more than 15, then we have an FP3 situation where we do the patient on removable restoration, on less implants, and we talk with him about the reality that he needs a bigger pink component or screw retained restoration. Another parameter which is very important is the form of the arch and the dimension of the arch. I talk with a technician and he has to measure the distance between the buccal cuspids of the premolars, because otherwise, after we inserted the implants more palatally, the technician is tempted to do a restoration which is more narrow than before, which gives or restores bigger black spaces or leaves less space for the tongue, which can give us phonetical problems. Now, the next dimension which is important and which we measure in the situation before is the overjet and the overbite, and we try to re-establish a physiologic proportion between 2 and 4 millimeters if it's possible. Now, concerning implant position, we know that a correct three-dimensional implant position in normal bone and soft tissue conditions can give us a very predictable, nice and pleasing aesthetic result. And the position means that the implant is placed palatally in the alveolar, 3/4 of the surface of the implant should be covered by bone, and the gap between the implant and the buccal plate should be grafted. In the depth, the implant should be placed 0.5 to 1 millimeter below the bone level if it's no polished color. Which are the parameters of immediate loading? Immediate loading means a provisional crown or bridge after the implant placement. The condition of immediate loading on an implant inserted in an extraction socket is primer stability, 3/4 of the surface should be covered by bone, and the gap should be augmented. In full arch reconstructions, all the implants which are loaded should be primed, should fulfill these conditions, and the bridge which covers those implants should be rigid. Now, the occlusal contact is not to avoid. Therefore, the patient is allowed to eat soft food for the time of the osseointegration, meaning 8 to 10 weeks. The idea behind is to give less stress to each implant, because each implant is allowed to have a 150 microns movement. Therefore, we follow the physical rule, stress is force through area. So either we reduce the force through soft food, or we increase the area through using more implants, using implant designs with thread design, which increases the surface of the implant, and also bigger diameter of the implants if possible. Now, we know today from Paolo Trisi that also in low bone density situations, we can get a primer stability as long as at least 45 Newton centimeter insertion torque is reached. So also in these conditions, the immediate loading is possible. What about the implant design? Which are there the parameters which are important? We start from the idea that the most or the biggest compromises and the biggest failures today in implant treatment are the aesthetic compromises and the periimplantitis. Both issues, both diseases, let's say, are in connection with the crestal bone loss. Periimplantitis is crestal bone loss plus infection. Where does the infection come from? From a poor hygiene, that is what we know. From overloading, that's what we know too. And a recent article of Linkovision shows us that residual cement is a main issue, a main reason for periimplantitis cases when the cementing is final. Now, nevertheless, Nevins shows that if we respect certain criteria and avoid all these issues, we can have 95% success after 10 years. Now, that means that we have to use all the details, all the issues that avoid or preserve bone loss, and increase soft tissue quality and quantity at the color of the implant. So how do we do that? We have a new equation in an editorial of Michael Norton, who shows us the relationship between the resistant torque, coefficients of friction, critical pressure on the bone, height of the implant, and diameter of the implant. So the most important criteria is there the P, the critical pressure on the bone, which we would like to predict, but in this equation is missing the viable structure, which is the density of the bone and in that region, and also the individual cutting character of the specific implant. If we could include those criteria, those parameters inside, and we could predict the critical pressure on the bone and prevent eventually bone loss. Now, on the other hand, the three implant design details which help us to avoid and preserve bone loss and improve the quality of the soft tissue and the color are platform switching, conical connection, and a certain philosophy of the running room in a provisional abutment and a final abutment. Now, platform switching is a design detail which is well known from the beginning of the 2007. And very many implant systems implemented this design detail in the system. Well, the huge advantage and the sense of a platform switching is moving the microgap from the level of the tissues, moving the micromotions and the bacterial pus from the tissues. And additionally, a non-surgical thickening of the tissue at that level, which we know that indirectly avoids or prevents bone loss, which we learned from Gargiulio. Now, the conical connection is proven to be one of the connections which transform the implant actually in a one-piece implant. But not any conical connection. The more tapered conical connection seems to be the most beneficial because it gives us the less micro movements, and the mechanical condition for a more tapered connection is a conical angle difference of delta alpha, which should be less than 0.25 degrees. This microgap is smaller than a bacteria, which has a dimension of 2 to 6 millimeter diameter and 1.1 to 1.5 micron in length. Now, the more tapered implant connection gives us the longest lasting reliability, 99% in comparison with 96% for internal hacks and 31% for the external hacks. That's what we learned from recent articles. We know that the highest complication in single tooth restoration is the screw loosening. And a conical connection has the property to absorb the vibration and the functional load. And of course, we are very disappointed when we cement Emax ceramic on zirconia abutment, and through the screw loosening, we have to perforate this crown and tighten the screw. So therefore, we need implants with a character of a single tooth implant or a single piece implant. Now, what about the grafting nowadays? Well, grafting has today also certain rules which makes the grafting predictable. And we notice that the grafting is more and more tissue thickness oriented. In a first row, in ideal situation, in ideal alveolar, we can do an immediate implant placement with immediate loading if we graft the gap, and in thin tissue biotype, we graft the gap and the soft tissue with a connective tissue graft or a membrane, as we will see in a few minutes. When we have a less buccal plate, a defect of until 3 millimeters, then we can do an immediate implant placement, immediate gap grafting, and a grafting of the soft tissue with connective tissue graft in thin tissue biotype, but we don't do an immediate loading because then the aesthetic result will be compromised. And we talk today not about the osseointegration success, we talk always about aesthetic success. No, now group 3, no buccal plate. Well, if the implant doesn't go out of the contours of the bone, we can insert the implant and graft this defect with a sandwich technique described by Homely Wang with autogeneous bone, alloplastic bone membrane, flap, but don't do an immediate loading, the aesthetic will be compromised. If we don't have interdental bone, meaning a vertical defect, then we have to go stage with a stage surgery. First, graft the bone and the soft tissue, and then insert the implant. A recent study of Atlanta group, New York group, and South American group shows that the best results, aesthetic results, meaning the less bone volume and volume generally, is reached when in immediate implant placement and immediate loading with a provisional crown, the gap will be grafted, the connective tissue, the soft tissue will be grafted through a connective tissue graft. Then we have the less loss of the volume of the tissues, also in the bone zone and in the tissue zone, meaning 0.2 or 0.3 millimeters. Other studies from Uli Grunder and a more recent one of Joseph Kahn and colleagues shows the same conclusion. Uli Grunder shows an increase of the volume of 0.34 millimeters when he used connective tissue graft. Joseph Kahn showed a bone change of 0.1 millimeter and a mean facial gingival level change of minus 0.05 millimeters, so very, very few. The conclusion is connective tissue graft in single tooth restoration with an implant or in symmetrical restoration. But if you have a full arch restoration, more and more membranes will be used, as we see in a few minutes. In a very nice book of Zucchelli, is shown that even if the implant is in a not right position, we can correct the optical outcome by grafting with a double connective tissue graft and over contouring this tissue. So let's see this single tooth replacement with an apical defect, which we solved with an ice cone technique with a collagen membrane type porcine origin, type 3 to 4 long resorption time, non-chemically cross-linked, and an inlay tissue graft from the tuberosity. The single thing that we have to consider here is to have a permanent contact with the tissues around and with the mesial and the distal tissues because of the vascularization which doesn't come from underneath. We cover this in order not to remove the mucogingival line. This is the provisional reconstruction. The provisional is no immediate loading, a provisional Maryland bridge. And after an uncovery with a small incision, we insert an individual abutment zirconia out of zirconia on titanium base. And you notice already the increased thickness of the tissue through the membrane, not through the connective tissue graft. And we use always a white abutment, not only in the thin tissue biotype, not only in the frontal area, also in the lateral area, because there is no aesthetic zone. All the mouth is an aesthetic zone. And the second reason is, even if we don't know from Ronald Young that in thin tissue biotype, the human eye will notice the difference between a white and a black abutment. But the tissue biotype will change also through the years, through metabolical processes. So we use always white abutments. This is the situation of the final crown. Notice the thickness of the tissue, which is also better than the left incisors, which already have a recession. Now, more and more studies are showing the properties or the benefit of a collagen membrane, porcine origin, type 3 to 4, long resorption time, not chemically cross-linked. The cross-linked structure gives us the long term of resorption, and the reality that they are not chemically cross-linked give us the issue that through metabolization there are no toxical processes if we have a small dehiscence, for example. This membrane in a very thick form we use today also in the covering of the recession. The usage of the membranes was documented already in 2007 and mentioned in the Osteology Congress by Busa and Uli Grunder. And today we can use this membrane, this thick collagen membrane, as I mentioned before, for recession covering with very, very good results. We don't have long-term results, but the 1-2 years results are very nice. Also, in grafting the soft tissue in full arch reconstructions, where a connective tissue graft will be practical impossible, then we notice a very nice quality of the tissue after uncovery, a thickness and a double of a thickness than before. Then this is only an observation, a study will follow. Now we use this soft tissue to protect the bone underneath and to build up the papilla between the implants. So we respect, of course, the timing of the healing. The timing of manipulation of those tissues after the healing is important. We know that the epithelium needs 6 days, the connective tissue needs 6 weeks, and the bone needs 6 months to heal. So we can manipulate these tissues only after 6 months after the implant placement and grafting underneath. Now, in vertical bone loss, we have rules which are the same, independent of the reality if it's an extraction socket, an periimplantitis defect, or a normal bone defect with a certain architecture. If it's a 5 bony wall defect, like the intact alveola, then we can do the grafting with an alloplastic material because we have enough bone potential from the area. If we have a 4 bony wall defect, then we miss one wall, we bring alloplastic material, but we bring also autogeneous bone or bone potential, and we cover it with a membrane in order to restore the defect. If we have a 2-3 bony wall defect, then we graft with an alloplastic material and we bring more autogeneous bone and or more potential, and the membrane will be more stiff in order to re-establish the defect from the volume point of view with a long resorption time. And if we have 1 bony wall defect, then we need a block grafting and we go 2 phases, or we have other technologies which we will see in a few minutes. No matter which kind of grafting we have, if we have to cover the graft, then we use different techniques of the soft tissue manipulation, which are very nicely described by Dennis Tarnow, Nicholas Elian, and colleagues, and classified in minor, moderate, and major flap advancement. This is vital for the success of the grafting. Now, when we have a defect which is more than 3 millimeters, the bigger the defect, the stiffer should be the membrane that we use. And we used to use PTFE membrane with titanium reinforced or not, but we have new methods today which are coming from the neurosurgery. This is a polylactid membrane which will be welded at a buccal wall usually, also on the lingual if it's necessary. We need bleeding points for the vascularization, and it will be welded with polylactid pins. Both the pins and the membranes are resorbable, but the resorption time is long, between 6 months and 1.5 years. We transform this vertical horizontal defect in a 3 bony wall defect. We can insert the implants to graft with alloplastic material and autogenous bone, cover it with a collagen membrane, and close it. So, for example, in this case, in the mandible, usually or before, I would have used bone blocks and wait and then do a second surgery for the implants. With this technique, we can do followings. We can do an immediate implant placement and immediate loading in the frontal area. Stabilize the buccal plate with the sonic weld and do a kind of horizontal vertical augmentation. Graft everything with the alloplastic material and autogenous bone from the environment, and cover everything with a collagen membrane which we prepare in advance, which we perforate in advance with a rubber dam instrument. In the lateral zone, we insert implants which are short, but they can be longer. They can be free 1 to 3 millimeters, and we use the healing abutment in order to support the tent effect. Then we weld the sonic weld membrane in that area, fill the defect with autogenous material and alloplastic material, and close the flap. You see how we close the flap also in the frontal area. We do a flap advancement so that there are no dehiscence and a complete covering of the membrane. Although the polylactid membrane metabolize with non-toxical products, water and CO2, and a collagen membrane above. And this is the situation which we get afterwards. So instead of 2 surgeries and bone block, the patient goes home with a fixed bridge and all the implants inserted in one session. Now, in a statical zone, we have here a young lady with 30. She has a left incisor, which is not a tooth, and a pin. It is a Tübinger implant which she got when she was 14, and it fractured when she was 16. And one dentist thought that it will be better to put an implant and a pin in the implant and stabilize it with a crown. Now the right incisor has an apical process, so it's the time to extract both teeth and insert implants. So we try to remove the tooth and the implant minimally invasive with less bone loss. We insert then the implants in the right aesthetical position, deeper as the bone level. We use the healing abutments of the system to support the tent effect, and then we solidarize, we graft vertically with a sonic weld technique. We graft the defect with alloplastic material and autogenous bone. So this membrane will make a wall, and then cover everything with collagen, with a collagen membrane with the particularities which I mentioned before. which increase the soft tissue quality and close the gap. You see is an over contouring of the grafting in that place. Now, this is the provisional, which looks already better than before because we have more vertical, we gain a bit vertical dimension. Then it improves with the time, and then because the lady had a gummy smile and the proportions between the length of the incisors and laterals were not there, we decided to do minimally prepped veneers on the frontal teeth. So this is the final solution. Now, on almost 100 implants, we did the sonic weld grafting procedure with hydroxyapatite and beta-TCP and a collagen membrane in combined horizontal and vertical defects, managing vertical defects of 3 to 6 millimeters with a simultaneous implant placement. We see the advantage of this procedure in the reality that we create and maintaining space with the membrane, which is stiff and resorbable. We avoid bone block augmentation in almost 60% of the cases, and we have the advantage that we do in very many times a simultaneous implant placement with a grafting, which saves 6 months of treatment and eventually another operation. So this grafting technique is also in a minimal invasive philosophy. Now, what about the prosthetics? What can we do? We gained, if you remember, we took an implant design which prevent the bone loss, platform switch design, conical connection. We make a nice grafting technique of the bone and of the soft tissue, increasing the soft tissue quality. Now, how can we manage with prosthetic parts this tissue that we gained? The challenge is in multiple implants. The single tooth implant where we have interdental bone is predictable. But if we have two adjacent implants where on the other side are two natural teeth, there is the challenge. And is the challenge to keep the volume, as we saw, the same volume, to preserve the volume, and more than that, to gain at least the same length of the papilla between the implants as on the contralateral side. Now, the reality that the papilla is shorter is not only about the bone, is also about the vascularization, which doesn't come from the periodontal space as in the tooth case. It's coming only from the periosteum. So, look at this case, and on the left side is a bridge. The right front tooth should be extracted. So I planned two adjacent implants with a hope that I can establish at least the same length of the papilla, which I have it in the original case, which is already smaller than the papilla on the left side because it is a papilla between a tooth and the pontic. Now, it wasn't an immediate loading, it was a closed healing, but individual zirconia abutments, but still the papilla between those abutments is flat. And I'm very disappointed when I see this black triangle between those crowns. But nevertheless, I put the crown, the contact point between the crowns normally, naturally, as Tarnow taught us, at 42% from the interdental space. So I see then, after 6 weeks, a slight growing of the papilla on the right side, and after 6 months, an establishing of a papilla, which is still a little bit shorter than on the left side, but in comparison with an original situation, which you see in the small picture. So we tend to have at least the same length. Now, we use for aesthetical zones, in conclusion, implant designs with platform switching design, which preserve the bone or avoid bone loss to a certain degree, the bone loss is in average 0.6 millimeter in comparison with 1.4 to 1.6 between two implants with a conventional design. What do we gain there? We gain supracrestal fibers, or we move the supracrestal fibers more to the coronally. So we can use this tissue for a gain of 0.5 to 1 millimeter tissue, papilla. Additionally, we use provisional abutment with a concave profile, which give us more volume of this supracrestal fibers or tissue. And we change it into final abutments with slight convex profile, which will push the gained tissue into the intercoronally place or triangle 0.5 millimeters. And this experiment came 2 years ago from Ernesto Lee and Weisskott, which published that in an article, and it is a very good method to gain 0.5 millimeter of a papilla, which is in symmetrical situation very important. Now, for frontal teeth, I tend to insert always tooth by tooth implant. In order, when I consider the hygiene issues and the bone loss issues when it's a young patient, and it was a closed healing, I used then concave profile of the healing abutments, and you can see the difference between a normal healing abutment and the concave healing abutment here. So this tissue that you see on the right side, on the left side, is gained by the concave profile of the healing abutment, in which we can use then for build up a little bit more the papilla between two adjacent implants. Those are individual abutments, zirconia. And now we construct the crowns with narrow triangles between the crowns and the contact point the way it should be, naturally. Now this is the outcome in comparison with the left small picture, which shows at least the same situation as before. Now 6 implants in the frontal area, same philosophy. Concave abutments, provisional abutments, and convex profile, slight convex individual abutments for the final ones. Those are the teeth, and this is the outcome. Now, in compromised bone situations, in the frontal area, for example, it's important to have the bone level and the bone volume the way it should be. So we can use for an immediate implant placement the bone splitting technique, which is very nice. The condition is to place the implant the way, in an aesthetical position, the way it should be, where we can work with an aesthetical template or a silicone key, which guide us into the implant placement. So this is the implant placement and peak abutments with concave profile and a provisional in the same session, which was made in advance. Now, for the final construction, final abutments and final crowns, we can of course change the emergence profile first and then individualize the impression coping, but in a full arch reconstruction is a huge work. Therefore, we are thankful that there are technologies which can offer us an emergence profile which is adequate and can stop 0.5 millimeter below the gingival margin or below the zenith of the teeth, which we plan. So again, digital techniques which allow us to construct the emergence profile and the preparation limit, let's say, of those abutments 0.5 millimeter below the gingival line or the zenith of the crowns that we want to do. So this is the outcome of the crowns in this full arch reconstruction. So we tend to gain through our prosthetic part philosophies at least the same papilla length as initially. The way we learned from Dennis Tarnow. Now, we use white abutment, as I mentioned, in frontal and lateral area, but never prefabricated and never full zirconia, because full zirconia breaks, it wears the internal life of an implant and is very expensive, and it's not individual. We use individual abutment in the frontal area where the preparation limit is 0.5 to 1 millimeter below the gingival zenith, and in the lateral area also white abutments which can be made paragingivally. Now, this case of this patient, which is a perio patient, needs implants because we see that after 1 year, tooth mobility is there and pus is there. And the height of the bone is less, in some regions, less than 10 millimeters. So in that moment, we decide implant is the method of choice. Now, the workflow in this case is, as I mentioned at the beginning of the lecture, we do pictures, aesthetic analysis, at least the 3-4 criteria that I mentioned, impressions, and a functional analysis through ZBRIS or Arcus Stigma, an electronic registration of the bite. If everything is physiologic, we go for the restoration. If it's pathologic, we go for treatment, functional treatment, and then we go for the restoration. In the lab, on the hand of all these parameters, aesthetic parameters and functional parameters, the lab will do in position 2 walks-up. The mock-up will be tried in a position 3, chair side, and if everything is pleasing, which can be documented in with pictures and videos, and if it's pleasing for the patient, then we do a temporary bridge in a form of a shell, which can be done digitally more and more, a temporary bridge in advance. In a position 5, we place the implant and we do an immediate loading if it's possible, and a provisional in the surgery. This is the provisional immediately in the surgery. And after the osseointegration, we have two possibilities. If we have an FP1 situation, then we need actually just an impression and a proper bite and a face bowl, of course, and we go then for the position 5, which is the final work insertion. If we have a FP2 situation, you remember we need a pin component, then the first thing is that we do an aesthetic try-in after the mock-up that the technician did. And if it's pleasing, we keep this situation with a silicon key, and from there the technician goes backward and is doing the abutments, the frame, and the final work in position 5. Now, this is an FP1 situation, so my technician was able to do the emergence profile the way I would like to have, 0.5 millimeter below the slight convex, 0.5 millimeter below the gingival margin by the zenith of the tooth that I want to have. You see the convex profile, you see the triangles between the crowns, which are narrow, and the contact points of the restoration the way they are actually normally in the natural teeth. And in the moment when we insert the abutments, we have a slight compressions of the tissues, which will be compensated in 30 seconds to 1 minute. And because we cement Emax crowns on zirconia abutments finally with a dual cement, we use cords to cement in order to avoid cement rests and a future peri-implantitis risk. Now you see the vascularization is compensated already, and the situation which my technician created in the model is actually the same situation which you can find then in the mouth after insertion. And this is the situation in after a few years of from the treatment. We always take a look how it looks like from the bone stability and soft tissue stability. This is the situation before, and this is the happy patient after. Now, the conclusion is, and my message is, that using the newest technologies of diagnostic and planning, using all the materials, methods, and techniques which makes our treatment minimally invasive, fast, efficient, and at the same time leading to a maximum aesthetic result is our contemporary target. We try to make out of daily activity work of art. And now I would like to thank you for your kind attention. Thank you.